All right, welcome back everyone from a break. So we're going to have a conversation now on microvascular disruption and non-thermal and mechanical ablation for brain tumors, GBM. And so we've got panelists here, Frédéric Padilla and Nathan McDannold. And I'm going to pitch this first question here that asks it to both of you. If you could share your own thoughts on sort of big picture ideas of how microvascular disruption or mechanical ablation can be leveraged for GBM therapy. And I think I'll pitch to Nathan first, yes.
I guess I'll start. So, I mean, the main, if we're talking about as an alternative, maybe for surgical resection, when we're talking about ablation, either with thermal or non-thermal mechanisms. And the idea of using microbubbles or emulsions to enhance focused ultrasound, the big promise is that it expands the envelope where we can apply ablation. So with thermal ablation, we're currently very limited on where we can ablate. We're limited to very central parts of the brain that are distant from the skull in all directions. With using a microbubble agent, you reduce the energy needed by orders of magnitude. And it allows you to sort of apply the ultrasound anywhere. With emulsions, you also get a reduction. The exact amount is less clear at this point, but it's also very promising. The big issues that that we need to come up with is how to control it, and I'm sure we'll talk about that. But I think having a way to non-invasively ablate tissue, either as an alternative for surgery or as a priming for an immune therapy, perhaps, is very attractive.
Yeah, so I was going to add that beside expanding the treatment envelope, at least what we are interested in is also this combination with other modalities. So it could be immunotherapy or that we just discussed in a previous discussion, radiosensitization, for example, using this type of microvascular ablation mechanisms. Yeah.
Yeah, and speaking to that, Nathan, I think you brought this up in your comments here. What advances in technology and methods are needed for moving this treatment strategy forward?
I mean, if we're talking about ablation, we need to have effective means to monitor what we're doing so that we know that we're putting the energy in the correct place, that we're putting in enough energy, and that we get the level that we need to get. The nice thing with thermal ablation is it's a very linear process. You heat the tissue 10 degrees, you can double the power, and you should get 20 degrees of heating. And you can look at what's going on before you ablate. When you're looking at microbubbles, either with injected agents or perhaps even histotripsy, sort of cavitation-based ablation, it's really a all or nothing approach where by the time you get the effect, you're just already causing damage. So that is, for me, that's the biggest technological hurdle we have. I think that it is solvable. There's some really nice results coming out using passive acoustic mapping transcranially, and for example, and from that you can get most of the things that you can get currently with thermometry. But for the device side, I think the devices that we have, we can go quite far in pursuing this if we can prove that this is something that we can control. There are other advances that you could make a more advanced transducer system to allow you to steer to larger areas, for example. But right now, I think the big issue is imaging guidance.
Yeah, I think that's a really good point. Fred, do you have additional comments or thoughts?
No, I totally agree. And I think one of the advantages maybe is also, the possibility to use lower frequencies. So in terms of technological approach, maybe that could also allow us to again increase this treatment envelope, and maybe it's not technological in terms of the focused ultrasound system, but if we think about the droplet vaporization, for example, maybe the composition of the droplet, the vaporization threshold, or is also something that needs to be that can be optimized to really trigger an effect at focus and to allow us to have a very precise treatment localization. I think this is one also of the advantage of this technology.
I'm going to ask each of you your own individual question here, because Fred, you have participated in the radiosensitization panel discussion, I believe, earlier. So in terms of monitoring and evaluating the effectiveness or the outcomes of the treatment, you have two different strategies that we're discussing here. One is a microvascular disruption. That doesn't necessarily mean mechanical ablation. Mechanical ablation could be much more, let's see, severe or extreme, approaching, or you could consider histotripsy as a form of mechanical ablation. So, Fred, in terms of evaluating, I'm going to pitch these to you individually. So, Fred, in terms of microvascular disruption, just thoughts and ideas on how to evaluate that. And then I ask the same question for Nathan, but in terms of non-thermal mechanical, like debulking or ablation.
Yeah, so what we are trying to do is to base our evaluation on the let's say success of the treatment on the biological outcomes. So again, in our current project, we are not trying to mechanically destroy, or it's not histotripsy we're trying to achieve so we're working in rats in intracranial brain tumor model with microbubbles, not droplets, with microbubbles. So what we are really trying to achieve is microvascular ablation in terms of blood flow stoppage. So what we are trying to use again is imaging. So it's MRI imaging, and more specifically, it's arterial spin labeling imaging to try to quantify the perfusion changes before and after the treatment. And the issue is that we are also exploring the possibility of doing multiple contrast injection during a single session to see, for example, if half an hour or 1 hour after the first one before treatment, we still have a contrast increase that could allow us to quantify a change in perfusion. But the most promising approach seems to be, again, arterial spin labeling. So this is at least the way we are doing it to evaluate the treatment.
And so, yeah, Nathan, with regards to mechanical ablation or debulking, for example, yeah.
Well, I mean, we're at the stage now where we're still in an exploratory stage, trying to understand the right parameters to use to get a reliable result. We've been working with you on some projects looking at droplet-based ablation, and that the results from that so far are very promising with respect to at least the rat model GBM that we use, which is a very dense, discrete tumor. Microbubble ablation seemed to be much less effective than the emulsions, and that could just be a delivery issue with getting large bubbles into these tortuous brain tumor vessels, and also having a higher concentration. So I'm approaching this right now as sort of a not necessarily as a GBM tool, and it's more of a way to do surgical ablation with ultrasound using adjuvants of bubbles or other agents. I'm speaking with the neurosurgeon on this. There's always a lot of skepticism because they always want to surgically remove the tumor, and that's going to be very, very hard to replace. And I think there are good questions about if we, ablate, volumes of tumor and leaving behind the content. So where, if you cook the tissue with thermal ablation, it takes a very long time for it to be removed. If you just shut down the vasculature, you get the tumors liquefied very quickly. And is that a good idea or not? But right now I'm at a much earlier stage, at least personally, looking at this. from a standpoint of how we can use these bubbles and how we can monitor them. And we're starting to look at how we can combine them with radiation and chemotherapy.
You bring up another really good point here, and that is based on your conversations with the neurosurgeons. So I pitched this to both of you, in case both of you have talked to neurosurgeons or neuro-oncologists. Out of those conversations, are there types of cancer? We're talking about GBM mainly at this workshop, but are there types of brain tumors that neurosurgeons or neuro-oncologists, kind of look at this and saying, this is actually something that could be applicable, could be effective, in terms of a treatment strategy?
I can't say I've had those conversations. I mean, I've talked about glioblastoma with them. Okay. Yeah. But I think there is a role. I mean, I'm sure it depends on who you talk to. They're going to do surgery if it's accessible. When you start to talk about recurrence, maybe then it becomes less obvious that what you would want to do, and maybe having a tool to go in and ablate the tumor is, something that's a good idea. I mean, overall, I think, that we could have a vision of having ultrasound therapy where we replace surgery, and then we go after the infiltration with, BBB opening. And I think that's an interesting goal, but we have to be careful and keep in mind what the clinicians tell us.
Yeah, I'm the same.
Go ahead.
No, I was say same here. We don't have a lot of discussion about other type of tumors yet.
Yeah, I tend to, I think recurrent glioblastoma could be a good target, given that virtually, at least what I've read, virtually all glioblastomas have recurrence. Last question, and it deals with, there's been a lot of conversation and talk about immunotherapy during these sessions. And so I'm curious, what you all's opinions and thoughts are with leveraging non-thermal ablation or microvascular disruption, how that might be leveraged for facilitating immunotherapy, if that might have a role.
I mean, I think histotripsy is very, an idea of using that to, to have antigen release might be is interesting, and maybe using the emulsions. I don't know using microbubbles if that is the right way to go. If you produce ischemia, is the inflammatory response that you're going to get what you want to have for an immune therapy? I don't know.
And Fred, last question.
Yeah, I tend to agree. I mean, we did not exploit yet in our protocol. I think it might be interesting with the combination of radiotherapy, especially, to see if we can improve this response. I mean, the response to the combined treatment, for example, if it's dependent on immunomodulation effects, because then we could start thinking about combining with, maybe it will be immune checkpoint inhibitors or other forms of immunotherapy.
Well, thanks so much for your participation on this panel. And we're followed actually by histotripsy, which was brought up a couple of times during this panel discussion. And so I want to thank you all for your participation and thank everyone for their attention.
Thank you very much.